Hello everyone. I am Simran Kaur and I am the moderator for this today's session. So I welcome you all for this clinical rounds with Jindal IVF, Session 6 for Series 1. So our topic for today is basic embryology for clinician. For this, I would like to introduce our speaker, Dr. Umesh Jindal, and who is the director of Jindal IVF. And our expert for the same is Dr. Sanjeev Maheshwari, Director IVF Embryology Lab, Jindal IVF. So I would like to hand over the session to Dr. Umesh Jindal, ma'am. Please, ma'am.
You must be wondering, dear friends, you must be wondering whether why Dr. Sanjeev is not speaking and why I am speaking, because I just wanted to keep this talk from the clinical point of view. And he is an expert and he's very knowledgeable in embryology. So his inputs would be of immense value for this today's deliberations. So before we start the topic itself, this session will be starting next course details 6:30 to 7:30 would be the next session, and four series of six session each: basics, ovulation induction, infertility management, and ART are the series. This is the last topic of series 1, and the next series would start on ovulation induction, various oral agents, gonadotrophins, IUI, CUHYY, and IVF protocols. Then OHS. Instead of this, we will be doing luteal phase support and then success rates. And we would be doing it on Wednesday. Please note down. This will be Wednesday and 6:30 p.m. 6:30 to 7:30 p.m. So today's topic we are discussing the embryology. So what are the objectives of today's presentation? That simplify complex embryology, focus on clinical relevance, and some insight in the IVF lab functioning. Although this is too short a time, but we'll try to get the only the clinical relevant points. Why should a gynecologist know about embryology? It's basically, if you don't know these steps, it's essential for patient counseling, whether you are a gynecologist or you are a practicing IVF specialist. Knowledge of essential embryology is essential for patient counseling. It correlates stimulation with embryology outcome, essential for gamete and embryo evaluation. Decision making is required, joint decision making is required uh, at every step from insemination till embryo transfer, and especially the day of decision, embryo transfer, and fresh or frozen. It also helps to explain IVF failures and also successes. Helps to explain add-ons, whether to use or not, whether to go for PGT, and understand the limitations of embryology. And it's very important to have a perfect collaboration with embryologists. So just a peep in the IVF lab. This is our IVF lab. IVF lab is a very compact kind of area where the main feature is the AHU, or what we call HVAC system, where the air circulates through the lab and through pre-filters, carbon filters, HEPA filters, and it is of class 10,000 uh, specifications, which means that there are less than 10,000 particles per cubic feet. And it's one of the purest kind of air which is there, and it's free of VOCs, particles, and fumes. It's a positive pressure ventilation. So air comes from here, goes out of the outflow tract, and also under the doors and this thing. And so the fresh air always is comes and goes out. This system is the one which keeps the IVF cultures clean, clear of infection, particles, VOCs, and it's a very, very important feature of any successful IVF lab. This is the workhorse, what we call as uh, clean air workstation, and it has a microscope in it. Uh, this is a dissection microscope. This is where we identify the eggs. We, and before transfer loading is then done here. And now these days they are attached to a TV. So for teaching purposes, or it's very easy now to see what's going on under the microscope also. The incubators, these are classical incubators, the box type incubators. They are these days now most of the cultures are not done here, but they can be used for culture also. But these are mainly used to keep media, disposables for calibration. They are kept there, which are big bottles, relatively big bottles. So these can be kept in these incubators. And you can see these are HEPA filters. These are individual chambers for every patient so that there is no mix up, and triple gas is there. And the main advantage is they're very small incubators, and the if you open the lid, they regain their atmosphere very fast. This is micro manipulator, which is again attached to TV. So magnification achieved in microscope is again you can see on screen, which is very big, and laser is also attached to this system. You can see is the laser, and the same micro manipulator also uses the uh, laser, and then this is used for mainly biopsy or assisted hatching. So coming to oogenesis and spermatogenesis. Oogenesis and spermatogenesis are not just materials which are required for embryo. They are basically the clinical determinants of success. IVFs will succeed only if we have good oocytes and good sperm. Age, lifestyle, environmental toxins, etc., have impact, and they may be responsible for aneuploid embryos and failures at embryonic stages. They may occur because of the gamete factor. There's a basic difference in spermatogenesis and oogenesis. The spermatogenesis, uh, no spermatogenesis occurs till puberty. Spermatogonia are there, and with puberty, the spermatogenesis starts under the influence of gonadotropins. They are type A cells, which are like stem cells, and they keep on multiplying and producing more spermatogonia as contrast. Excuse me, please mute yourself. Please mute yourself. Their spermatogonia, which keep on producing more spermatogonia. So there is an endless supply of stem cells, which can lead to sperms. And then there are category B spermatogonia, which are now committed to develop into sperm cells, and then they change into primary spermatocytes, and the various stages of meiosis are achieved. While in females, the difference is the meiosis starts during intrauterine life. We all know that. And primary oocyte, secondary oocyte, then arrested at metaphase. We'll come to this part a little later. And then finally, metaphase 2 oocytes are ready for fertilization. The basic difference is meiosis. In males, meiosis does not start till puberty. Spermatogonium stay as potential stem cells, and there is a potential population of spermatogonia which keeps on producing more spermatogonia. Sperm cycle takes about 3 months. This is one important part which you must remember to complete meiosis, because if you're giving any therapy, so you cannot expect a result before 3 months. And in female, meiosis starts at intrauterine life, and oocytes are arrested in the Pachytene stage of the first meiotic division. This is the clinical correlates which you need to understand. Oocytes recruitment, when we start recruitment, it prepares the ooplasm and nucleus for resumption of meiosis. Meiosis is only triggered when LH surge starts. This is important because many I till the time I was not I had not started IVF, and even much later this fact I understood much later, that meiosis starts only after the LH surge. First meiotic division is completed at, even after that when it starts, it's not completed in the body of the woman uh, in IVF. Otherwise, it obviously does in body only. First meiotic division is completed at ovulation. So it takes after start it takes about 36 hours to 40 hours to complete meiotic division, first meiotic division, and second meiotic division after insemination, the sperm penetration. Otherwise, it does not happen. It stays at as first it ends there only. So stimulation is all about producing follicles which have competent oocytes. And how, what we say about competent oocytes, what does it mean by competent oocytes? Ovulation of OI is about developing multiple follicles with resumption of meiosis in a successful way. We'll come to this, what we mean by successful way. The when menstrual cycle starts, there is activation, and activation means this oocyte starts gaining the ooplasm increases. It collects all the factors which it requires to nourish the oocyte, and the nuclear maturation is there. Nucleus does not start meiosis; it only matures and it is ready to undergo complete its meiotic division. And this thing happens under the influence of gonadotropins, that meiosis is resumed at this stage when after the LH trigger, and then ovulation occurs. So the maturity is assessed by the appearance of cumulus mass at the time of zona. Cumulus mass and zona after the ovum pickup. Oogenesis, if we simplify that in the embryology terms, there are GVs, there are M1, which lead to M2, then there is fertilization, and then there is two polar body stage. Clinical correlation is more with trigger timing or onset of LH surge and immature oocytes at OPU. If we get too many immature oocytes at OPU, then it's more likely that the trigger has not been done properly or the stimulation has not been done properly. Although there can be insults at the time of ovum pickup because of increased pressure or something, but by and large, if mature oocytes are not identified, then one has to review their stimulation and trigger. Immature oocytes are a very common cause of failed fertilization, and clinically oocyte maturity predicts success. This is the beautiful cohort of oocytes which you usually see after an ovum pickup. These are immature oocytes, and these are little abnormal. And here there is, dispersion of, Dr. Sanjeev, would you like to comment here?
Yes, I will like to. I think common question after pickup is clinician comes and asks you, "Okay, sir, oocyte कैसे हैं?" This is the question we are supposed to answer. We say, "Okay, ठीक है जी, number ठीक है." One thing is number, which is exactly told to the pickup surgeon. Then we say, "Okay, there is nothing to comment." When we say there is nothing to comment, it means oocytes appears normal. When we say oocytes are very small, they are compact, it means they are more likely GVs. When we say oocytes are something like dark, very tiny, there is almost no cumulus mass, it means that these are almost degenerated cells. So ovum pickup gives us a oocyte which should be very competent, as madam has already told. They should be mature. So mature oocytes are just expanded cumulus with a clear cut dot which predict that it is a mature oocyte. So This is the requirement for the further success. So two things we are to keep in mind: number of how many oocytes are there, and second thing, what is their status likely to be. Sometimes it is not better to comment too early on the oocyte maturity. Let them be incubated for say half an hour to 2 hours. They may gain hydration and all that. Immediately after hydration, sometimes oocyte cumulus size decreases. But if it gains, then you can easily say these are mature oocytes. So this is the point which we, as embryologists, we should tell the clinician, and clinician should keep this in mind that what is the quality of the oocyte and what are the likely chance of further fertilization, cleavage, etc.
Okay, and see, these are the terms we commonly use, and you must be seeing if once we give the final report uh, after uh, after an IVF case, you may have seen that many centers give this kind of report that how many GVs were there. GVs are actually oocytes. This is the still GV stage is the fully grown oocyte, and it is still primary oocyte which has not resumed meiosis, or maybe it has just resumed meiosis. So it looks like a cell with the nucleus. Then
One
I'm
thing more I will like to add here, as Madam has already told you, meiosis resumes within the body of the female, but it is not completed there. So where it is completed, when you are doing an ART, when you are doing pickup, it is completed from your tubes to the lab part. So that period is very, very crucial. We are supposed to handle the oocyte in a very delicate fashion during their exit from the body of the female to the lab, because if there is a fall of temperature, or if there is fall of pH, we are likely to stop that meiosis which had resumed in the body post trigger. So that is the valuable period, that is valuable time we have to keep in mind. So both clinician and embryologists are supposed to be very, very careful. So clinician should hand over the uh, pick up oocyte in a very good environment at a very uh, temperature 37 degree and at a very good pH, that the medium which it is being handed over, that should be ideally incubated, and that should be at a pH around 7.1. Only then these oocytes will continue their journey further. Otherwise, all the cycle will stop here.
okay, and these are M1 oocytes which have resumed meiosis, but they are still 2N. Still the first meiotic division has not been completed. And this is the beautiful oocytes M2, which usually occurs at the time of ovulation, but when we see after denudation at the time of ICSI, then we are very sure that this is a mature oocyte. So this is again, now this is 1N. Well, the first meiotic division has occurred, and this is secondary oocyte by the other term. This is secondary oocyte. And then finally, after ICSI or with natural in IVF sperm fertilization, when sperm enters the inside the oocyte, the two pronuclei develop. These are the one male, one female nucleus. You can't distinguish; they look same. And second polar body is extruded at this stage. So this is called zygote, and these pronuclear stage is seen for a very short time, and after that syngamy occurs, they mix, and then it looks again like a, but then we can see diagnosed fertilization, evidence of fertilization by presence of two polar bodies. So what goes wrong, what can go wrong at OPU? If there is poor recovery, the number is not good, poor quality, the quality is not good, or they are immature oocytes. So this is one first step where if they are good, then we look for a good outcome of IVF. What is the, Roxanji, what is the prognosis for poor quality of oocytes in this cycle and next attempt? What do you think? If oocytes are not good in the beginning, what happens? And
I would- oocyte first, as you have already mentioned, number. What is the expected number? This is available from the uh, uh, ultrasound monitoring, which you have done, follicular monitoring. If we have, say, there were almost 5 to 10, more than 10 follicles of a size more than 15 when you give the trigger and you are getting only 2, 3, then definitely there is something wrong. And quality and immature oocyte that can also be judged from the after immediately after the pickup. If there is good cumulus and all that, it is mature oocyte. If it is less, so death prognosis is exactly entirely dependent upon the what is the status at the OPU. I don't say, okay, if it is very poor, definitely we are worried what to do, how to inseminate them. If there is good number, we can go for ICSI as well as for IVF so that we can cover all the risks of conventional IVF failure and all that. But to what point we should relate these wrongs at the OPU? Is it intrinsic or stimulation or something like that lab procedure? As I have told you, sometimes your trigger may be poor, trigger may not be sufficient to allow the resumption of meiosis. Then lab procedure can also be faulty if you are not handling the oocyte at a proper temperature, at proper pH. Even resumption of meiosis may be arrested after the retrieval. So all these factors we have to analyze point by point. But quality
So,
depends also on
yeah.
the age
So,
of the patient, BMI of the patient, etc.
etc. So it may be patient related. Patient related, you can only say when it happens for the multiple times, or there are clear cut factors like age other factors are there. So then you can say that it may be intrinsic to the patient. Then
Timing of trigger is very, very important. If you are not doing the pickup exactly at 34 to 36 hours, probably you are likely to get immature oocytes if you are doing it too early. If you are delaying it, there may be already you may not retrieve the oocytes. There may be premature rupture of the oocytes. So timing of the trigger is very, very important. And what trigger you have given, agonist trigger or you have given the SCG, and what is the dose of that. Moreover, whether you have used urinary HCG or you have used recombinant HCG, everything has a role in the resumption of the meiosis.
yeah, and also that whatever stage they come out of the body, they usually behave like that. They do mature in vitro, but they still their behavior after fertilization depends on at what stage they come out. So even a mature oocyte may have abnormalities. In addition to maturity, there may be abnormalities of polar body, like zona. It may There may be some big or small perivitline space. There may be debris. Then ooplasm also may be abnormal. So you can see all kinds of pictures. We see uh, all kinds of pictures are there for oocytes. And this oocyte is like look at this polar body which is so big, and all these abnormalities, all these oocytes are generally not fertilized, and they do not lead to embryos. And these are again, it's very difficult to say it's patient factor or some other factor which has contributed. In general, many of these things are not recurrent, but we have seen like these giant polar bodies occurring in majority of the oocytes, aspirated and repeated also. So these things do repeat also, but the granular cytoplasm, degenerative oocytes, they may not repeat. So it doesn't mean that if you had one cycle of poor oocytes, then next time you have to do donor egg. Doesn't mean that. You can still try one more cycle, but if it is repeated, then yes, then you the option remains of donor egg. But otherwise, one cycle you must give another chance, especially if the female is young. Then sperm source. Sperm source, most of the times we use ejaculated, and we always keep a backup frozen sample because there may be instances when the husband is not able to come, and he is not able to come, and then we cannot allow the cycle to get wasted. So we keep and we discard the sample after the case is done. Donor sperm cases, obviously, we have to keep the sample arranged and keep with us. And testicular sperm now these days are very successful. It can be TISA, where we just aspirate. In cases of obstructive azoospermia, we can just aspirate from testes, or it can be PISA, where we just aspirate from the epididymis, and TC, where take a biopsy. But here uh, the best technique which has come recently is the microtasy, where you open the testes, identify the active tubules. Especially these are very important in cases of atrophic testes or hypergonadotrophic azoospermia, where the FSH is high, and you diagnose as atrophic testes, small testes, little small, very small, you may not be able to get, but in general, the recovery rates are anywhere between 60 to 70%. And these are very difficult cases for embryologists. To find sperms from these tubules may take anywhere from 1 hour to 3 hours before they declare that you can't. It's a negative or unsuccessful procedure. Methods of sperm preparation now these days, there are a lot of fancy things which have come up. The standard techniques remains swim up and density gradient, which were there earlier, but microfluidics is something which has recently come. It has a potential of there's no preparation. You just put a drop at one end and the good sperms come out at the other end, and all the debris, all the damaged cells are separated, and the cells, the sperms which are coming out, they come there by their own power, their own motility, and so this is not applicable for very poor samples. And these samples, but otherwise, this is one thing which has been recommended for DNA fragmentation cases. uh, poor, then again the sperm have to be good motility, only then this is effective. You cannot use it with severe asthenospermia cases. Then similar is pixie cases. These are basically, these devices are for normal semen to select the best possible sperm here. IMSI once came. It's a advancement over ICSI, where the sperms are selected even higher microscope, higher magnification, and these sperms again are not very. Uh, it's a very tedious procedure, and it's not costly. Also, this machine is also very costly, and it has not picked up very much in most of the centers. So, any want to add, Dr. Sanjeev?
Yes, definitely. I want to add something about microfluidics. Microfluidic is a technique which should be ideally used in a patient of say above 35 or 40, because these are the patients where DNA fragmentation is known to be very high. Even when the your female age is high, even then give the sperm which are best sperm, because old oocyte cannot handle the sperm which are DNA fragmented. It cannot autocorrect many things. So microfluidic the technique which should be ideally used when there is a lot of chances of DNA fragmentation, high BMI, or even in a higher age of the male partner. This is what I like to suggest. Second is scandally, this as Madam has already told, IMSI is not picking up, so I will go for PIXI instead of IMSI. And then standard method should be your density gradient, not the swimmer, because a lot of debris can be removed by this density gradient. But microfluidic only when you expect a high DNA fragmentation. Even there is not a documented, but probability is that DNA fragmentation will be high. That is what I would like to say here.
I have a question related to microfluidics. Suppose there's a patient with high DFI and that cannot be avoided. So in that case, what should we go for to give the patient and to put the patient on antioxidants, or to go for the usage of microfluidics directly?
Definitely antioxidant, they say that it's an empirical rule. You are never sure because how much time it will take. Sometimes it may take 3 months, sometimes it may take 6 months. Moreover, you are never sure how much ROS is there in there because we are only doing qualitative ROS analysis. There is no almost there is no way. I will not say there is no way, but there is no available way how to test. So the dose of the antioxidant depends upon the quantity of the ROS. So it is better to select the sperm which are where DNA is intact. So when you go for this microfluidics, you will find your sperms are absolutely DNA, in, intact DNA. So I will not say, I will not depend. You can use antioxidant. I am not against that.
Dr. Sanjeev, continue the discussion. I have lost my slides. I am reloading them.
One more question I have. Sir, is there any impact of using more flushing media or to when we flush the follicle more and more? Does that like affect the quality of egg?
Sanjeev, please answer me. I'm just trying to find my slides. Hello,
Sir,
Simran?
are you there? Yes, yes, ma'am. I think sir is there. Sir,
Sorry, I lost my connection.
okay, okay.
Sorry, I lost my connection. I have regained it.
What was the question there?
So the question is the extra use of media. Like ideally, only 2 ml per pickup, 2 to 4 ml is enough. So if we use more media to flush the follicle, does that affect the quality of oocyte?
One thing is for sure, you should avoid flushing at all, if possible. It is the only aspiration for which you don't need much of the media. But
And actually,
if
these
there is
days we are
already
not using at all. Flushing we don't use at all. It's only when there is some bleeding or some the needle feels that it is stuck, then only we use flushing. Okay, Dr. Sanjeev, one question I've written. You are very fond of IVF. So most of the patients think ICSI is better. So what do you
no,
think
I
of
don't believe.
ICSI?
Actually, there is nothing to choose between IVF or ICSI. ICSI has its own indication, IVF its own indication. If your sample is oligo, motility is low, then definitely there is no way to go for IVF. But if your sperms are good, high in number, there are hyperactive sperms, and there is no previous evidence of DNA fragmentation, etc., then it is the only conventional IVF. There is no need to go for ICSI.
Actually,
ICSI,
we will have to, this is very important that the natural IVF or IVF still selects sperm in the natural way, and we trust nature to do the best. So IVF is the routine. ICSI is done only for special cases like Dr. Sanjeev has mentioned, or we do when as a backup if we have enough oocytes, then sometimes we divide and do both ICSI and IVF. And frozen sperm, like many husbands are not there, so we are using frozen sperm. Do you think it has any? Does it affect an outcome or no?
definitely, frozen sperm it should not be the choice. It should be only option in case there is failure to collect sample, patient is having fever on that particular day, something goes wrong, so that only then we should use that frozen sample. Definitely, it has, uh, I will say, compromise the results. Uh, def- it is only a substitute. It is not the choice.
Okay. And testicular
Even
sperm.
with a very even a very good sperm freezing, you will not be able to get more than 40% viable sperms. This is what the so when there is a dead sperm, probably possibility of ROS and everything increases. Moreover, cryoprotectant are already there, which should be avoided.
Okay. So, and testicular sperm, even with very bad, azoospermia cases, and we get testosterone, they are barely moving. So, still you get very good results. What do you say about that? Dr. Sanjeev? Okay,
I think
I would
again.
like to add here that the testicular sperm are still very good because it's basically the delivery of DNA material inside the oocytes, which is important. And most of these female patients, female partners of these patients are young, and so they can take care of many things. And the results, once we are able to identify sperms in testicular sample, the results are fantastic.
Definitely, because testicular sperms are almost free of DNA fragmentation. DNA fragmentation occurs during the travel of sperm from uh, testis to ejaculation. Their stay is almost 70 days in this track. If you are avoiding all the things, probably your sperm you are selecting, it may be difficult to select, it may be difficult to collect, it may be interventional to collect. But once collected, their results are far, far better than normal sperms, ejaculated sperms.
Okay, now coming to oocyte, and this is the stage when M2s are there. And one thing we have to remember that oocytes only M2s can be frozen. There's no point in freezing the GVs or M1s, right, Dr.
Yes,
Sanjeev?
madam. Yes,
Yeah.
yes, it is right. Definitely, oocyte freezing. First of all, why we are doing oocyte freezing? When male partner is not there, only for social reason, fertility preservation, and all that. But the survival of oocyte is poor. Why it is poor? It is not because of the technical skills of the embryologist. It is because of its size. As you know, oocyte is the largest cell of the body. So it is very difficult to dehydrate such a large cell. Moreover, as you have already told, we are to freeze it only at M2 stage. So at M2 stage, there is no nuclear envelope. Mitotic spindle is already lying within the cytoplasm. There is no protection of that. And when you are doing that, probably survival is compromised.
And this is age related again. How many oocytes are required at age to get a reasonable rate of success? Even at age 30, you should have more than 15 or 20 oocytes frozen to get a reasonable pregnancy rate, live birth rate above 90% or something like that. And as you go older, you need more and more eggs. This table is very classical, and I mean, this is one thing. Whenever you are recommending oocyte freezing to anybody, you have to take care of that, because many older women, they might have to go for multiple cycles of stimulation and egg retrieval before they have a reasonable number of oocytes for as a security for their future fertility. But in
Definitely,
case,
as the
yeah,
age
but in
in the advanced,
onco cases, we freeze whatever we have so that whatever chance they have, that should be there.
so definitely in the advanced age, NPLD rates will be much, much higher than the younger age groups. So you need a very high number of oocytes for a live birth.
Okay. And then fertilization and cleavage check. These are very important things which embryologists do. The evidence of fertilization is checked at 18 hours post insemination. So that comes to around 8 a.m. in the morning, and Dr. Sanjeev comes very early in the morning and looks at these oocytes, because otherwise these PNs will dissolve, and then these PBs are sometimes very difficult to identify, and then it's only at cleavage that we will know that this embryo is further developing or not. But cleavage, even a triploid embryo, where here there may be more than two PNs, so even a triploid embryos can develop further. So normal PN, two polar bodies. Abnormal, it can be 0 PN, 1 PN, 3 PN, anything can be there at this stage. Two cells are seen at 24 hours post insemination, but very few people see it because that comes in the evening. But four cells are seen at 42 hours, that is the 48 hours roughly after OPU, and A cell 66 hours, next day, day 3. And on these days, at 48 hours or 72 hours post pickup, these embryos are either shifted to blastocyst medium or frozen or embryo transfer is done depending upon the clinical situation and joint decision of clinician, patient in consultation with the embryologist. And this is the stage which is very often there is a point of I would say discussion between the clinician and the embryologist, and patients also ask क्या करें अभी freeze करें blast बना के freeze करें and all that. Both options are good. You can grow them to blastocyst, and finally, because nowadays we are not doing many fresh transfers, so we grow them to blastocyst and freeze. In certain cases where you have to do like PGT, biopsy has to be done, then anyway you have to grow them to blastocyst and then see. In failure cases, again we prefer that you, because you know that blastocyst will develop or not, at least you know in what the exact situation the patient would be knowing. But sometimes if you have plenty of oocytes, embryos, you can freeze them and then grow them again before transfer to blastocyst and then transfer. The both options are there, and both options have their pros and cons. Then embryo grading is again embryologist job. You can see here mainly, it's done on the basis of presence of fragmentation, the number of blastomeres, the size of blastomeres which may be there, and like this is anybody can say that this is a very poor quality embryo, and usually these are useless and are discarded. These grade 1, 2, and this 3 are unpredictable. The grade 1 and 2 usually would develop into good embryos, but grade 3 is unpredictable. Sometimes autocorrections are there and they may also develop into good embryos, and they may be euploid also. So you should not be discarding any embryos at this stage unless you are sure that they are arrested and not growing further. How does Dr. Sanjeev, patients usually say very good quality embryos were there, but still the pregnancy did not happen. What do you say about this grading and that statement?
But gradings definitely for recording purpose, analysis purposes. But I always use the word, these are appealing embryos. These will end in pregnancies because their look is some different. When you see daily, probably you will be able to identify. You have to see compaction. You have to see their arrangement, spatial arrangement. Are they lying separate? If there are on day two, there are four blastomeres, there are eucal, but they are not very close. They are not approximating each other. They are lying almost. They are joined to one another, but they are not compact in a compaction stage. So compaction is one thing which I will say that embryo is appealing and will end in pregnancy. Moreover, with very good embryos, you can have failures. Why? Because you are never sure of their genetics. These may be employed embryos. I have seen many times very, very good blastocysts. When I say we biopsy them and when we read the report, they are not euploid. So chance of failure with a very good embryo and ploidy is the main reason probably. Then definitely embryo is one point in the success of a IVF cycle. If your endometrium and all that is that good, patient's age and all that, what was the how was the procedure? These are the factors which you are supposed to keep in mind. So aneuploidy from the lab view is the major cause of failure from a very good embryo, very good blastocyst, you can say.
If anybody has any question, please interrupt and ask, or please write in chat box so we can take it simultaneously. So now blastocyst culture is the standard of care, but you remember that the embryos are staying for 5 days outside the body, and perfect lab and incubators are required for successful blastulation. Even in best of the labs, only 50% of good embryos will develop into blastocysts. So we can't expect more than that. This is important because many times patients may ask कि इतने अच्छे एम्ब्रियो थे डे 2 पे और बनी तो बाद में थोड़ी सी blastocyst. So this point I think I would like to emphasize to all gynecologists that acceptable blastulation rate is 50%, but it can be less, it can be more. So blastocysts can be transferred in fresh cycle, frozen or biopsied, and then frozen and then transferred later on. But nowadays, this is the hatching blastocyst. It's a rare, I would say, pleasant sight to see these hatching blastocysts, but these can be the cause of monochorionic twins also. If you
I
transfer,
will like to explain one thing here. As madam has already told you, expected rate of blastocyst is 50%. So please don't expect in every case, if there are 10 embryos, 5 will be the blastocyst. You are to look for 100 embryos of say 10 patient. You can expect from that 100 50 blastocysts. So if you think इस पेशेंट में 4 थी 2 बननी चाहिए, दिस इज नॉट द ट्रूथ. आपने 10 पेशेंट का देखा, उसमें 100 एम्ब्रियो था, तो 50 बनने चाहिए आपके. दिस इज दी how you should analyze your data. Every patient, if you look at the individual patient, it will not be. Please mute.
Who is talking in the background? Please mute from your side.
ये जलंधर है.
Hindu Muslim was the last thing dividing.
Please mute so that we can continue. So I have explained already. Every clinician should not expect 50% in each case. Every patient, every clinician should 50% in their entire lot, say 5 to 10 patients. This is how you are to look at your data. Don't be depressed if there is no blastocyst in 1 or 2 cases. And you will be, don't be very happy if you are having almost 100% blastulation rate in 2 or 3 patients. This is the way you are to look at the things.
Okay, then blastocyst grading. Again, these are blastocyst grading is again very tricky because the blastocyst, keep on contracting and please unmute.
Someone named with Shweta. Please mute yourself.
Shweta,
Still unmute.
okay. So this is blastocyst grading is also very tricky. They are stage 1, 2, 3, 4, 5, and it is staged on the basis of trophoectoderm, inner cell mass, and blastocele cavity. The first thing you see is whether it is expanded or not. The size of the zona gets thinned, and the size of the whole structure is increased. Excuse me, please. It's disturbing.
Shweta ma'am, please, if you can hear us, please mute yourself.
Okay, so blastocyst, on the basis of blastocele cavity, then trophoectoderm, whether it is compact, few cells or very scattered cells are there, and inner cell mass, where it is a compact, a good number of cells are there, or it is again less numbers and it's not that compact cell. So it's based on that, blastocyst grading is done. And depending upon that, again, you decide the order of transfer of these blastocysts. And these days, when we are freezing, again, we freeze them in the order of grading, so that at the time of taking out, at the time of embryo transfer, you are able to transfer the best blastocyst in the first attempt. Dr. Sanjeev, would you like to add anything here? Dr. Sanjeev? You lost him.
Now there is, yes, you have already told the grading depending upon the cavity, just cavity grade 1, less than half grade 2, and all that. If your cavity is almost to the full, it is grade 4. If it is exceeding your zona 5, if it is ruptured, then grade 6. Then you should look at the trophoectoderm. Ideally, it should be regular, compact, plenty of cells should be there. There should not be any degeneration. If there is, you are to avoid blastocyst transfer in case if there is any degeneration. Otherwise, you can transfer grade 1, grade 2, grade 4, grade 5, grade 6. No problem.
And you still get good, and you can do biopsy in all these grades. Which one can you biopsy and which one you cannot biopsy? Hello, Dr. Sanjeev?
Not do any biopsy. You should avoid biopsy in a blastocyst of grade 3 or less than that. You
Oh,
should attempt biopsy only in a grade 5 of where cavity is up to the zona or grade 4, not below the. Ideally, it should be hatching blastocyst that should be biopsy.
hatching.
Hatching. Ideally, it should be hatching, or you can attempt at the grade 4 or grade 5 also.
Okay. To grade 3 also you can attempt. No. Okay. And you remember these grades are 5 is the best one and the 1 is the lowest, lower one, opposite to the what the grading of early cleavage stage embryos. So this is one odd thing here which confuses, many times. So few words about blastos biopsy, PGT. I will not say much here, and I think by now most of you know about PGT. A is for testing for aneuploidy, and the common indications remain. I will come to that. Monogenic disorders is PGT-M, and HLA matching also can be done in these cases. And PGT-SR is when there is structural chromosomal arrangements, translocations, inversions, deletions, etc. in the parents. And what is PGT? What actually is the advantage? That every embryo represents a potential pregnancy. And PGT gives you the outcome of many pregnancies in one go without going through the repeated transfers, failures, uh, prenatal detections, and abortions. One can diagnose and prevent imminent IVF failures and risk of inherited diseases and miscarriages because of embryonic causes. And there is reduction in time to pregnancy along with financial, physical, and psychology cost of repeated misadventures. So the technique of biopsy remains mostly now these days blastocyst biopsy is done. Now nobody is doing day 3 biopsy because it is safer for the embryo. The repair of this trophoectoderm is very fast, and there not much damage is done to the embryo, and there are no long term consequences so far reported with this technique. There are many techniques which can be followed in the lab, but briefly speaking, you make a hole in the zona, you aspirate the trophoectoderm, you separate it out, you cut it with laser, take the biopsy, and send it for testing. So it is a highly technical job, not easy, and it's a long learning curve. But this anyway, now most of the young embryologists are learning to do it, and I think this will become more common like ICSI, and most of the embryologists would be doing this technique. Then coming to vitrification, it is a rapid and advanced over slow freezing. Highly concentrated cryoprotectant solutions are used, and rapid cooling is done at 10,000 centigrade per minute. It's a very fast. You just dip it. You take it and you just dip it. And rapid cooling prevents ice crystals and cellular damage by achieving a glass-like amorphous solid state. It's more effective than slow freezing. There are higher survival rates. Precise timing and handling are required, so there is a definite learning curve for vitrification. And cryoprotectants can be toxic to the cells, but by and large, the vitrified embryos have given very good results. The children born are healthy, so there's not much damage which has been reported. And embryo transfer is the final success determining step. It can be done on day 2, 3, or 5, but now the standard is 5. We hardly do on day 2 or 3. And fresh or frozen embryos can be done, but in West, I think in Europe, most of people are going for fresh, but otherwise now I think in India, most of us are now shifted to frozen embryo transfers. And number of embryo transfer depends on many prognostic factors: age, of oocyte, or in case of OD, BMI, previous failures, embryo quality, M2 rate. And euploid status, if you know, if it's a PGT embryo, then you can go for a single embryo transfer. Now, more and more patients also are opting for single embryo transfer. Many centers now, with the increasing confidence in embryos and in embryo selection, are moving towards single embryo transfer, and that should be the target, that we have a singleton uh, term live birth. And counseling, you have to tell the patients about the number and quality of embryos, pros and cons of different days of embryos, day 2, day 3, or day 5, and how many numbers of embryos are to be transferred. We discuss with the patient. So I'll always be decide after discussing with the patient on the day of embryo transfer. And if there are any doubts regarding procedure, that are clarified. Freezing or discarding of extra embryos, most of the times we do freeze them, and only if they are not of good quality, then the extra embryos are discarded. But with and they are informed, and they put it in writing that how many embryos are being discarded, or how many embryos are being frozen. One very important point is we take consent again for frozen embryo transfer. Although it's not mandatory by law, but we always, as a precaution, we take, because frozen embryo transfer sometimes is done after some time, 2, 3 months, 4 months, 5 months. And many times one of the partners can withdraw their consent, especially the male partner, and this has happened. So we always take another consent before doing frozen embryo transfer. And also in cases of poor embryos where transfer is done and chances of implantation and miscarriage after transfer may be there. So all these things are taken into in consent. And interestingly, these are also covered under PCP&DT, and Form F is also filled for all OPOs and ETs. Embryo transfer, these are the disposables which are required, and the catheter loading is again a highly specialized technique where very fine coordination is required to load the embryos in very less volume, zero point 0.2 micron or something. How much volume do you take of media, Dr. Sanjay?
From 10 to 12 micron.
10 to 12 micron, and so it's a very
Yes.
and it's a very thin flexible catheter which keeps on moving, vibrating, and so it's a again a learning curve in loading the catheters. And then these are transferred at the this is called maximum implantation point, right at the center, where both the tubes are, all three orifices of the uterus meet, you can say that, in that line. And this we can see under ultrasound. Now with experience, was 1 centimeter below the fundus, you know where to transfer. And by and large, ultrasound is really really helpful in placing the embryos at the right place. So trial embryo transfer is again, because many of these women have very crooked cervices. So trial embryo transfer does give an idea that it's going to be easy or difficult. Ultrasound guided has to be there. There are many types of catheters which uh, specialists can choose. Full bladder is required. Then placement of catheter is again very important. And it's a very, I mean, the time to complete procedure is one factor which affects outcome. If from loading to transfer is long, then it can interfere with the success rate. We usually put the external catheter first, then tell the embryologist to load after that, and then after that, it just I think 20 seconds or like that we are able to deposit the embryos in the uterus. Then we recheck the catheter for retained embryos or blood or mucus on the catheter. There are now advances which are coming up. Time lapse is the one, AI is one, where it gives you a score, and embryos can be selected on the basis of AI scoring systems. The time will only tell whether they are improving the outcome or not, but basically it's only a selection method. And if yeah, if your culture conditions are good, if oocyte sperms are good, then perhaps your manual methods and time lapse, they're still comparing. But if you have a difficulty in selection, then obviously it takes the morphology, also it takes the morphokinetics, which means that development stages it takes into consideration. And AI based algorithms are there which give you the speed of development should not be too slow, it should not be too fast. Again, it has to be Goldilocks optimal time at what all the cleavage should occur. So it selects the best embryo, definitely yes, and hopefully it will improve the success rate. But this is little early to say whether it will improve the success rates. Most of the RCTs are reserved on this point whether it does improve success rate, but it does improve the workflow, the understanding of the embryologist, the learning skills of the embryologist. So it's a useful tool which is coming up now. Then there are many, other add-ons which may be there in the lab, like time-lapse embryo glue, microfluidics, sperm selection techniques, hatching, ERA, SCG, GCF. I think they're all their topics in their own right. So today I will not be discussing, but one thing I can say that these again may not add on to lot of success, but obviously everybody strives to get better success, and especially in problem cases. Then in the end, I would like to highlight few criminal offenses which can be there in IVF labs. Unless we are taking care of this and we are strict with ourselves, these things can happen, and plus not only ethical, lead to serious legal issues. Deliberate or even inadvertent mixing or substitution of gametes. This is one of the most serious offenses which can occur. Dr. Sanjeev, what precautions do you take in your lab to avoid this?
One thing, simple precaution. There should be only one couple's gamete at your workstation at a time. Keep them in the incubators only, then remove others. This is the best way to avoid mixing. Second, only do one case at one time. So this is the way of to avoid the mixing. Secondly, there should be witnessing. These days, lot of witnessing on the electronic. I am not of that very strict electronic witnessing, but definitely one should one person should be there who is observing you, and he should not speak until you are making a mistake. So this is the way how you are semi stop. This is the how you are to you can avoid the mixing or substitution of the gametes. So this is the only way I will say do one case at one time. Keep them in the incubator only, then remove the second one.
Then law again prohibits giving oocytes or embryos or sperms to anybody else without even with permission you cannot give. You have to route through the donor bank. So that's again a very very serious offense. Incorrect information regarding quality or quantity. You give a report that everything was fine while the embryos were not good. So again, this is a very ethical issue, and this actually can be challenged many times in the court of law. But this is one ethical issue which is there, and it should be avoided. The charging for procedures which were never done, like embryo glue, hatching, and these things that you charge the patient, but they were not done. And gender selection, obviously, in India, there's no way you can do it. And even if you do PGT, that does not tell you the gender of the embryo. So in the end, you have to, see these stages, stage wise, you have to take decisions, and, you keep on thinking whether you're done open pickup today, whether you're going to get good blastocysts. So, I mean, that is the thing in the end, which gives you a healthy baby. So, with that, I would like to end here, and this is our next ovulation inductions with the oral agents, and this would be after Diwali, I think on 28th, 27th or 28th, this is going to be. So, we would like to now, this may be more clinical and maybe more interesting for you. This series, first series was basically basics. I don't know how much useful it was. We would like to have your feedback on this series and our attempt to, spread the uh, awareness about IVF and everybody. So please give your feedback also. And if you have any questions, we are open for answers.
Thank you, ma'am. I would
May I-
like to thank ma'am and sir
any question?
to enlighten the basics, and it was all very well explained. So we can go for questions if anyone has any question. Please.
Simi, you have any comments?
I want to convey all my clinician friends, please don't over expect something. Sometimes you are over expecting this is the OD case, we should like get blastocyst like this and all that. Yes, you have given us a good oocyte, but there are other factors you have to keep in mind. So you cannot expect success in every case. Try to bear with the failures also, because you have to one thing more, if there is any previous history of any ART cycle, you should consider that very carefully, and you should give importance to all the shortcomings of that cycle, because that may be repeated. This is what my message to all my clinician friends.
And Deepa? Hi, Deepa. Dr. Deepa Goyal?
Hi, Umesh.
Would you
I-
like to make any comments here or questions if you
Yeah,
have any?
I think these 6 sessions, out of which I think I did attend 3, and then others I have been just listening to. I think these basics actually are very important. No, I don't think there would have been any boring thing in this. And this, the one which you have talked today, I found it very excellent. Maybe because I'm not very knowledgeable about the embryology. So I think it helped me a lot actually. And
Thank you.
I,
Thank
and I always like to learn new things. Maybe it is because of that. So I remember the days they used to say, "Mm, all ICSI, all ICSI." Hmm? And
Yeah.
now it has changed, no?
Yes.
So it has changed now. So things keep on moving so fast in the technology. It's always good to be updated about these things. I'm quite happy to attend all these sessions.
Thank you, Deepa, for the encouragement. And we'll continue with our endeavor to spread knowledge. And with that, we can, end this session. And thank you very much, everybody, for joining. And we'll still appreciate feedback from everybody.
Thank you.
Thank you.
Thank you.